Welcome dear students, I am Dr. Pratyusha and in this video let us learn about tubercular otitis media. It is one special type of otitis media that is caused by Mycobacterium tuberculosis. In this video, let us see all the features of tubercular otitis media. First, the etiology. TB otitis media is usually secondary to pulmonary tuberculosis. While coughing, the bacilli come into the throat and via the Eustachian tube they travel into the middle ear and cause tubercular otitis media there. It's also possible that sometimes it is It is also possible that sometimes it occurs as a blood-borne infection or contact with infected sputum or by drinking milk from an infected cow could also cause tubercular otitis media. But the most common route by far is secondary to pulmonary tuberculosis. Blood-borne and direct contact are rare routes. Tubercular otitis media is slow and gradual in its onset and progression. It is more or less a painless process. It is a painless pathology. If we look at the pathophysiology of tubercular otitis media, the most salient features are it is slow and insidious in onset and progression. Tubercles are seen as the main feature. And where are the tubercles seen? In the submucosal layer. Tubercles in the submucosal layer of the middle ear cleft and even caseations are seen. First we find tubercles and this is followed by caseative type of necrosis, which is the classical feature of tuberculosis anywhere in the body. The mucosa of the middle ear in tuberculosis shows thickening, edema, and infiltration by joint cells. Mucosa shows thickening, edema and infiltration by joint cells. These are all present as the most important features. And then the tympanic membrane shows painless necrosis. And now comes the most important feature, that is spontaneous multiple perforations. Spontaneous multiple perforations are seen in the tympanic membrane. CSOM usually produces a single perforation. Even traumatic perforations are usually single, but multiple perforations are a classical feature of tubercular otitis media. Now these multiple perforations at a later stage, they may coalesce and form a single perforation later on. But initially it is multiple. These are the most important features of pathophysiology of tubercular otitis media. One is there are tubercles. Then we find caseative necrosis in the subepithelial layer. Then we find caseative necrosis, Mucosa shows thickening, edema and infiltration by giant cells. Tympanic membrane shows painless necrosis, and most importantly, multiple perforations are seen. Now let us look into the clinical features of tubercular otitis media. First is ear discharge. The ear discharge is thin, scanty and odorless. Thin, scanty and odorless type of ear discharge is seen. But if there is a secondary pyogenic infection, then it changes to purulent or mucopurulent and foul smelling. If there is a secondary pyogenic infection. After ear discharge, the next feature is hearing loss. The hearing loss in TB otitis media occurs very early and it is severe. It is out of proportion to what we see, to the extent of the disease. Mostly it is conductive type of hearing loss, but sometimes a sensory neural hearing loss component could be present if labyrinthitis occurs as a complication of tubercular otitis media. The next feature is facial paralysis. Why would facial paralysis occur? Because of the involvement of facial nerve in the disease process, and usually in children this is the presenting feature. Because the ear discharge, hearing loss and whatever changes that are occurring, they are all painless and sometimes do not bring this to the attention of the adult or the child. So directly facial paralysis occurs and that is when the child presents. Facial paralysis is a very common complication of TB otitis media. It's not something rare, it is in fact the most common complication. After these clinical features, now let us look at the signs. Upon examination, what we find is, first thing, as I told you in the pathophysiology, multiple perforations in the tympanic membrane. Multiple perforations of tympanic membrane are seen, and also there is extensive granulation tissue. Extensive granulation tissue in the middle ear cleft. You can see a picture here. This is how TB otitis media would look. There are multiple perforations along with granulation tissue, extensive granulation tissue. And then sometimes the preauricular lymph nodes are enlarged. Preauricular lymph nodes are enlarged. Upon doing tuning fork tests, we find moderate to severe hearing loss, mostly of conductive type. These are the most important clinical features of tubercular otitis media. Now let us look into the diagnosis part. First, we collect the discharge and send it for culture and sensitivity. And what we find is tubercular bacilli. If at all there is some secondary pyogenic infection, even those bacteria can be found. In the culture media. If we do a histopathological examination, that would show granulation tissue. Repeat, that would show granulomas. After a secondary pyogenic infection has occurred, it is very difficult to diagnose tuberculosis unless we have a preceding history of tuberculosis in the person. And for that, sometimes doing a chest X-ray might help to narrow down into the diagnosis. And other evidences of tuberculosis are important, such as a DNA probe or a polymerase chain reaction. These give early results and they also help in identifying tuberculosis as the cause. Now moving on to the treatment part, receiving systemic anti-tubercular therapy is the most important thing to be done. Systemic anti-tubercular therapy. A full course has to be taken by the patient. This is the most important thing to be done. And for local treatment, we can do oral toileting to clean the discharge and other debris that are formed. And for ear per se, even after giving tubercular therapy, if there is no improvement or if complications such as facial nerve paralysis, mastoiditis, caries of the bone, osteitis, they have all occurred, then surgical treatment may be necessary. And surgical treatment is usually in the form of mastoidectomy, if complications are present, and the healing is generally delayed in tuberculous cases. Even a wound breakdown and fistulas are very common, and sometimes reconstructive surgery of middle ear may be necessary if the middle ear ossicles are extensively involved in the disease process. These two are the surgical procedures that are usually done. But it has to be remembered that without medical treatment, even these surgical therapies will not be fruitful. So this is all about tubercular otitis media. The most important thing is, if it is presented as a clinical scenario, you should be able to identify. Question will be framed such as, a patient presents with hearing loss. Upon examination, there are multiple perforations in the tympanic membrane that are seen. This is the most important clue and hint that an examiner can give you. And the second most important hint is, this entire condition is painless. Please remember, tuberculosis anywhere in the body is always painless, except TB larynx, which is painful. Rest all tuberculosis is always painless. Now looking at the picture, it is sometimes hard to believe that something that is undergoing so much of necrosis, there is so much of granulation tissue, plus all these tubercles, it's hard to believe it is painless, but it is actually painless. So that is the second part of the question. First, you will see multiple perforations of the tympanic membrane with extensive granulomas and tubercles, and on questioning, the patient says that there is painless ear discharge, that is scanty and only once in a while seen. The patient is not bothered about what's happening in the ear because he can neither feel the pain nor is the discharge very profuse. But on examination, you will see this picture. And then they will tell you that the hearing loss is out of proportion to the perforation that is seen. Small multiple perforations will be seen. It's hard to imagine that the patient is having so much of hearing loss. And in the history, you might get that the patient was suffering from some fever and took treatment for 6 months or 9 months. So this gives a hint that maybe the patient was had tuberculosis, and for that only he was undergoing this treatment. Now what is your diagnosis? It is tubercular otitis media. So this is about TB otitis media. I hope you have understood it in detail. Thank you very much.